Welcome to Bookfulness. This is episode 5. In the last deep dive, we detailed the regional anatomy of the vertebrae and the joints of the vertebral column, laying the foundation with the bony framework.
And today, we're closing out chapter 2 of Moore's clinically oriented anatomy. We're building directly on that skeletal structure we talked about. Our focus shifts now from the passive supports to the active systems. So the mechanics of the back, the really complex muscle groups that power movement and maintain posture.
Right.
And maybe most critically, diving into the vital structures housed within, the protected confines of the vertebral canal.
Our mission today, then, is to connect that rigid, segmented, bony framework we study to the soft tissues, the neurovasculature, and just the functional realities that give the back its stability, its mobility, and its crucial clinical relevance. We're going from simple anatomy to complex physiology, really. Okay, let's unpack this by starting right at the very top of the column. #tag1 Tamid. Craniovertebral joints and movements.
Yeah, so when we talk about the spine, usually we're focused on intervertebral discs and the zygapophygeal joints, right?
Standard setup.
But the region where the spine meets the head, these craniovertebral joints, they're completely unique.
Oh.
Evolution basically demanded maximum mobility here.
Oh, okay.
And that necessitated specialized joints that, well, they deviate significantly from the pattern you see elsewhere in the column.
And you can see that structural demand immediately. Like you said, no typical intervertebral disc between C1 and C2 or between C1 and the occipital bone.
Exactly.
Instead, you've got these two key joint sets that give us those really fundamental head movements we use all the time.
Right. First up, the atlanto-occipital joints. This is where the concave superior articular facets of the atlas, that's C1, articulate with the occipital condyles of the cranium. You can sort of picture these like two rockers sitting in two shallow troughs.
Okay. Yeah.
And because of that shape, these joints primarily permit the yes movement, so flexion and extension of the head on the neck, nodding.
Nodding, yes. Got it. And if that gives us the nod, then the no movement, the rotation, that must happen at the next level down.
Precisely, at the atlantoaxial joints. And it really is brilliant engineering. It's all centered on the dens of the axis, which is C2.
Dens?
Yeah, the dens acts as this perfect pivot, or you could say an axle, and it's secured within a ring.
Ring formed by?
Formed anteriorly by the arch of the atlas, C1, and then posteriorly by, well, arguably one of the most vital ligaments in the entire body, the transverse ligament of the atlas.
Okay.
And that relationship, the dens spinning securely within that C1 transverse ligament ring, that allows for roughly half of all the rotation in your entire neck.
Wow. Half of it just there.
Yeah.
But that incredible degree of mobility, it must demand some serious ligamentous reinforcement, right?
Oh, absolutely.
Because if that transverse ligament fails, the dens could shift backwards.
Exactly. It can shift posteriorly, potentially invading the space for the spinal cord, and that's a catastrophe. So the ligamentous system here acts like multiple layers of armor, really. Beyond just the transverse ligament, we have the anterior and posterior atlanto-occipital membranes.
Okay.
These are basically extensions of the anterior and posterior longitudinal ligaments, and they span the gaps between the occipital bone and the C1 arches.
And clinically, something important happens there.
Yes, it's worth remembering that the vertebral arteries actually penetrate that posterior membrane to get into the cranial cavity.
Ah, okay. Good landmark.
Then we also have the larger cruciate ligament, sometimes called the cruciform ligament. It's cross-shaped, as the name suggests.
Right.
It combines the transverse ligament horizontally with strong superior and inferior longitudinal bands vertically.
So even more reinforcement.
And then we find the alar ligaments. These extend sort of obliquely from the sides of the dens upwards and outwards to the lateral margins of the foramen magnum.
And their job?
Their job is primarily to limit excessive rotation and also lateral flexion. They act like check reins. But what's really important to note here is that structurally, they are weaker than the transverse ligament.
Weaker. So they can tear more easily.
Potentially, yes. If the alar ligaments tear, say, in a severe whiplash injury or maybe a combined rotation type of trauma, it significantly increases the range of contralateral rotation.
Contralateral, so rotation to the opposite side.
Exactly, by about 30% more rotation, so they really are the secondary rotational checks.
Got it. Secondary checks.
And then finally, covering everything deep to the skull base, you have the tectorial membrane. This is this strong, broad, superior continuation of the posterior longitudinal ligament.
Yep.
And it attaches finally right onto the floor of the cranial cavity. So this whole system, layered like it is, provides incredible protection for that critical junction between the brainstem and the spinal cord.
Okay, fantastic protection for the head-neck junction. So we secured the head. Now let's zoom out a bit to the rest of the column. What about general vertebral column movements? We know the overall flexibility comes from adding up tiny movements at, 24 distinct segments?
That's exactly it. The movement, flexion, extension, lateral flexion, and rotation, it's passively permitted by the elasticity of those intervertebral discs.
Right, the cushion.
Yeah, but it's actively limited by the zygapophyseal joints, which act kind of like guides or rails, and also by the longitudinal ligaments, which act more like restraining belts.
And the spine isn't uniformly flexible, is it? It's regionally specialized.
Highly specialized. The cervical and lumbar regions are definitely the most mobile. This is largely because their articular facets, those zygapophyseal joints, are oriented more horizontally.
Okay, more horizontal allows more.
More flexion and extension primarily. It facilitates that massive range of motion, allowing you to, say, touch your toes or look straight up at the ceiling. Most of that bend comes from the lumbar and cervical spine.
Okay, so neck and lower back are built for bending.
Yeah.
What about the middle back, the thoracic region?
Conversely, yeah, the thoracic region is much more limited in flexion and extension. And the main reason for that is the attachment of the pretty rigid rib cage.
Makes sense. The ribs brace it.
Exactly. If you try to bend forward, you'll notice most of that movement really happens in your lumbar spine. However, the thoracic region allows the greatest degree of pure rotation.
Ah, interesting. Why rotation?
It's thanks to the near vertical orientation of its articular facets that allows the chest wall to twist quite significantly.
So regional specialization. But that also means regional vulnerabilities, right? Which brings us straight into the clinical implications.
Absolutely.
Let's start with probably the most common spinal failure people hear about, herniation of the nucleus pulposus. A slip disc, as people call it.
Right, the slip disc.
Yeah.
And that acute, sharp, localized pain people feel initially, that's associated with the disruption of the tough outer layer of the disc, the annulus fibrosus. Usually it happens posterolaterally towards the back and side.
Okay.
When that inner gel-like nucleus pulposus bulges or herniates out, it often hits the posterior longitudinal ligament first. And that ligament, along with the adjacent bone and disc, is heavily innervated by these recurrent meningeal branches of the spinal nerves. Ah, so that's the source of that initial deep, localized back pain.
That's the initial signal, yes. But the radicular pain, that burning, shooting pain that goes down the leg or arm, that comes from direct compression or irritation of the spinal nerve root itself.
And you mentioned this mechanism is profoundly different between the lumbar and cervical regions.
Yes, absolutely. And you really need to grasp this distinction for clinical correlation. It's fundamental.
Okay, lay it out for us. Lumbar first.
Okay, in the lumbar region, the IV discs are the thickest, right? And the lumbar nerve roots travel downwards within the dural sac for a bit before they actually exit the intervertebral foramen.
They descend first.
They descend. Therefore, if the L4, L5 disc herniates posterolaterally,
Okay.
it usually pushes against the nerve root that is passing by that level but is actually destined for the level below.
Ah, so it misses the nerve exiting at L4, L5.
Usually, yes. It
Oh.
typically impinges the nerve root exiting one level lower. So an L4, L5 disc herniation most commonly causes an L5 radiculopathy symptoms related to the L5 nerve. Okay, L4, L5 disc hits the L5 nerve. That's counterintuitive, but makes sense with the descending roots. Now, what about the cervical spine?
Now shift your focus up to the neck. Because of the way the cervical nerves exit more horizontally and directly,
Right.
a herniated disc there typically compresses the nerve exiting at that same level.
Okay, so straightforward.
Much more straightforward. A C5, C6 disc herniation usually compresses the C6 nerve root. That's the critical difference you need to remember. Lumbar hits the nerve below, cervical hits the nerve at the same level.
Got it. Lumbar level below, cervical same level. That's a key takeaway. Okay, moving back up to catastrophic neck injuries. We talked about the transverse ligament's importance. What happens if there's a rupture of the transverse ligament of the atlas?
If that ligament ruptures, the dens becomes unstable. It's no longer held tightly against the anterior arch of C1.
So it can move?
It can move posteriorly, especially when the head is flexed or rotated, and it can then impinge directly on the spinal cord passing through the vertebral foramen of C1.
And this is where that Steele's rule of thirds comes in, right? To understand the potential severity.
Exactly. It provides a useful perspective on the immediate prognosis. The rule basically suggests that the space within the C1 ring is roughly divided into thirds. 1/3 is occupied by the dens,
Okay.
1/3 by the spinal cord itself,
Right.
and 1/3 is effectively space, containing cerebrospinal fluid, ligaments, and vessels.
So there's some wiggle room initially.
There is some initial buffer space.
Yeah.
To cause severe compression like quadriplegia or even death, the displacement of the dens needs to be significant enough to encroach upon and compress that middle third, the spinal cord's territory.
Which explains why some patients might be deceptively asymptomatic right after the injury before swelling or further movement occurs.
Precisely. That initial space can mask the severity until later.
Okay, shifting down the spine again, let's look at structural weaknesses, particularly things like spondylosis and spondylolisthesis. These sound complex.
They can seem complex, but the concepts are fairly straightforward. They're common issues, especially in athletes involved in high-impact sports or activities with repeated hyperextension, like gymnastics or diving.
Okay, so what's spondylolysis?
Spondylolysis is essentially a stress fracture or a defect in a specific part of the vertebra called the pars interarticularis.
The pars, where's that?
It's the slender bridge of bone that connects the superior and inferior articular processes on the back of the vertebra.
Okay.
On an oblique X-ray view of the lumbar spine, this area, along with other parts, creates an image that looks a bit like a small dog, often called the Scotty dog.
The Scotty dog sign, I've heard of that.
Exactly. And if that dog appears to have a collar or a break in its neck, that corresponds to a fracture or defect in the pars interarticularis. That's spondylolysis.
Okay, so lysis means a break in the pars. What about listhesis?
Now, if that defect, that spondylolysis, occurs on both sides of the vertebra,
Bilateral, okay.
it can destabilize the vertebral body above it. And if that vertebral body then slips forward on the vertebral body below it, most commonly, L5 slipping forward on S1.
Ah, the whole thing shifts.
Yes, due to the failure of that bony connection at the pars, that forward slippage is spondylolisthesis. Listhesis means slippage.
And that slippage would narrow the vertebral canal.
Dramatically. And it can cause significant mechanical low back pain and also nerve root compression, leading to radiculopathy.
Makes sense. Okay, finally in this section, we need to quickly review the 3 classic abnormal curvatures of the spine. The spine's curves are normal, but too much is pathological.
Correct. The normal curves are there for shock absorption and balance, but excessive curvature is a problem. We talk about excessive kyphosis, often called hunchback or dowager's hump.
That's an increased curve in which direction?
An abnormal increase in the posterior curvature, usually most noticeable in the thoracic region. You often see this in older individuals with osteoporosis, where the front parts of the vertebral bodies collapse or wedge.
Okay, kyphosis is posterior. Then there's excessive lordosis.
Lordosis is the opposite swayback. It's an abnormal increase in the anterior curvature, concave posteriorly, most commonly seen in the lumbar region.
And a third one.
The third is scoliosis. This is different because it's an abnormal lateral or S-shaped curvature when viewed from the front or back. And crucially, it's almost always accompanied by some rotation of the vertebrae as well.
Scoliosis is lateral plus rotation. Now, what's interesting about lordosis is how common the mechanism causing an increase in it can be in everyday life, right?
Oh, absolutely. Think about late-stage pregnancy or someone carrying significant abdominal obesity.
Right. The weight is anterior.
Exactly. That extra weight anteriorly displaces the body's center of gravity forward. To compensate and maintain balance, to prevent falling forward, the individual unconsciously increases their lumbar lordosis. They lean back, essentially. Right. But this forces the back extensor muscles, the erector spinae group, to work constantly, contracting isometrically to resist that anterior pull of the weight.
And that leads to?
That leads to chronic back strain, muscle fatigue, and often the painful spasms that people experience. The increased muscular work is just unrelenting. It highlights the link between posture, weight distribution, and back pain. #2, curvatures, vasculature, and nerves at the vertebral column.
That discussion on lordosis leads perfectly into the overall structure of the spine itself. Like you said, the vertebral column isn't meant to be a straight pull. It's this stack of small segments forming an S-curve.
Exactly. That curve provides elasticity, flexibility, and crucial shock absorption. It really acts much more like a spring than a rigid pull.
And that complex S-shape is defined by the 4 distinct curvatures of the adult spine. You mentioned we categorize them based on when they appear developmentally.
That's right. We talk about primary curvatures and secondary curvatures.
Okay, primary first.
The primary curvatures are concave anteriorly, meaning they curve outwards towards the back, We call these kyphoses or kyphotic curves,
And those are.
the thoracic and sacral curves. They develop during the fetal period when the whole body is curled up in that flexed fetal position.
Ah, okay. They're primary because they're there from the start, essentially.
Pretty much. And they're retained structurally because the posterior parts of the vertebrae and the discs in these regions are slightly taller than the anterior parts, maintaining that backward curve.
Okay, so thoracic and sacral are primary kyphoses. Then the secondary curvatures must be the others.
Right, the cervical and lumbar lordoses. These are concave posteriorly, meaning they curve inward toward the front.
And they're secondary because.
Because they develop after birth. They are entirely a response to gravity and achieving motor milestones.
Like what?
Well, the cervical curve develops when a baby starts to gain neck strength and learns to hold up its head, looking around.
Right. Lifting the head creates that curve.
And the lumbar curve develops a bit later when a toddler learns to stand upright and begins walking. It helps position the trunk over the legs for balance. It's a really fantastic example of form following function. The spine adapts its shape to meet new physical demands.
That's fascinating. Okay, once that structure is established, it needs a constant supply of fuel and nutrients. Let's talk about the arterial supply to the vertebrae themselves.
The blood supply to the vertebrae is distinctly segmental, which mirrors the overall segmented organization of the spine and body plan.
So, different arteries at different levels.
Exactly. The vertebrae receive blood via segmental arteries that are running laterally through the body wall at that particular level. So you have vertebral arteries contributing in the neck,
Okay.
posterior intercostal arteries in the thorax, lumbar arteries in the abdomen, and lateral sacral arteries down in the pelvis.
And these main arteries then send branches to the spine.
Precisely. These main segmental arteries give off spinal branches, which then enter the intervertebral foramina, those openings between adjacent vertebrae.
Okay, they go through the foramina.
Sure.
And then.
Once inside or near the vertebra, they branch again. They form peristeel branches that supply the outer surface of the bone and equatorial branches that penetrate towards the center of the vertebral body. And importantly, these spinal branches also supply the contents of the vertebral canal itself, the spinal cord, meninges, etc., which we'll get to.
So, a pretty robust segmental supply. Redundancy seems key.
It is, especially for structures bearing constant load. But if the arterial supply is somewhat redundant and segmental, the venous drainage is truly unique and has some really significant clinical implications. We're talking about the vertebral venous plexuses.
Right, and you mentioned something unique and, frankly, a bit terrifying about this system earlier, the lack of valves.
Exactly. That valveless nature, especially in the internal plexuses, is the absolute clinical key here. It allows for pathways of spread that might not otherwise exist.
Okay, describe these plexuses. There are internal and external ones.
Yes, we have the internal vertebral venous plexuses, which lie within the epidural space, that space between the dura mater and the bone.
Inside the canal.
Inside the canal. And then we have the external vertebral venous plexuses, which lie on the external surfaces of the vertebral bodies and the vertebral arches.
Okay, and they connect.
They communicate extensively with each other, and they also connect with the large basivertebral veins. These are big, tortuous venous channels housed deep within the substance of the vertebral bodies themselves, draining the bone marrow.
So, a complex network. But why is the lack of valves so important?
Because the entire internal plexus system lacks valves, blood flow within it isn't necessarily unidirectional. It can actually reverse direction based on pressure changes in the body.
Like when you cough or strain.
Exactly.
Yeah.
Coughing, sneezing, straining during a bowel movement, or even lifting heavy weights, these actions all increase intra-abdominal and intrathoracic pressure. This pressure can force blood from the veins, draining the trunk organs, like pelvis, abdomen, chest, backwards into this valveless vertebral venous system.
Bypassing the normal route through the liver or lungs.
Correct. Since this system also communicates freely up and down the spine and eventually connects with veins inside the skull, like the dural venous sinuses, it serves as a direct, open conduit, almost like a venous highway bypassing the main caval system filtration points.
And the clinical implication there is.
The major clinical implication, as we touched upon, is that this provides a major route for the spread of infection, or perhaps more commonly, metastatic disease, particularly from cancers in the pelvic organs like prostate or ovarian cancer, or the abdomen or breast.
Wow. So cancer cells can travel directly up the spine to the vertebrae or even reach the brain or skull via these internal valveless veins.
That's the unfortunate reality. It's a significant pathway for skeletal and cranial metastases. It's a staggering piece of, you might say, engineering failure from a containment perspective, but it's a direct consequence of a system likely designed primarily to manage rapid pressure fluctuations without vessel collapse.
A trade-off between pressure management and containment. Okay, that's a crucial point about the veins. Now, let's consider the structures that actually feel pain in the back passé. The innervation of the vertebral column itself, not the muscles yet, but the bones and ligaments.
Right. Pain, whether it's acute from an injury or chronic from degeneration, has to follow a specific nerve pathway. The fibroskeletal structures, meaning the periosteum covering the bone, the ligaments holding things together, and crucially, the outer third or so of the intervertebral discs, the annuli fibrosi.
Okay.
These are innervated primarily by the recurrent meningeal branches of the spinal nerves. These are sometimes also called the cinevertebral nerves.
Recurrent meningeal. Why recurrent?
Because after the main spinal nerve forms and exits the intervertebral foramen, these small branches actually turn back around, re-enter the vertebral canal through the foramen, and then distribute to these deep structures within the canal and around the vertebral bodies and discs.
Oh, okay. They loop back in. And they carry pain signals.
Yes, they are largely sensory and vasomotor. They are the nerves responsible for transmitting that sharp, acute, deep aching pain associated with things like IV disc disruption, periosteal irritation from fractures, or ligamentous sprains. They sense the deep structures.
Okay, so recurrent meningeal nerves for the discs, ligaments, periosteum. What about the little joints between the vertebrae, the zygapophyseal joints?
Those are innervated differently. The zygapophyseal joints, also known as facet joints, which are true synovial joints, allowing gliding movements.
Right.
They receive their innervation from the posterior rami, or dorsal rami, of the spinal nerves. But here's the really crucial detail for anyone dealing with back pain clinically.
Right.
It's specifically the medial branch of the posterior ramus that supplies these joints. And even more specifically, each medial branch typically innervates the facet joint at that vertebral level and the facet joint immediately inferior to it.
Wait, so one nerve supplies two adjacent joints, or rather each joint gets nerves from two levels.
Exactly the latter. Each zygapophyseal joint receives innervation from the medial branch of the posterior ramus at its own level, and from the medial branch of the posterior ramus from the level above.
Dual innervation. Why is that so important clinically?
It's critical for pain management procedures targeting facet joint pain. If a patient has chronic pain stemming from an inflamed or arthritic zygapophyseal joint, and you want to perform a procedure like radiofrequency ablation or rhizotomy to burn the nerve supplying that joint,
Right, to block the pain signal.
you absolutely must target the medial branches of two adjacent posterior rami, the one above the joint and the one at the level of the joint. If you only target one nerve level, the joint is still partially innervated by the other level, and the pain relief will likely be incomplete or short-lived.
Ah, that makes perfect sense. You have to get both contributing nerves.
Precisely. It really underscores how detailed anatomical knowledge directly drives the success or failure of clinical interventions.
Okay, so we've covered the bones, joints, ligaments, vessels, and nerves of the column itself. Now, let's shift focus to the engines of movement and stability, the muscles of the back. And you mentioned there's a fundamental divide here.
Yes. The first thing to grasp is the functional divide. Extrinsic versus intrinsic back muscle.
Extrinsic first. What defines them?
The extrinsic back muscles are relatively simple in concept. They are primarily concerned with moving the upper limb, the appendicular skeleton, and, to some extent, the ribs during respiration.
So they connect the trunk to the arms.
Exactly. They are generally more superficial, and they connect the axial skeleton, the spine and ribs, to the appendicular skeleton, the shoulder girdle and humerus.
Examples.
Think of the big, sheet-like muscles that give your back its breadth and shape. The trapezius covering the upper back and neck, the latissimus dorsi covering the lower and lateral back,
The lats.
the levator scapulae and the rhomboids, major and minor, deeper to the trapezius. These all attach the scapula or humerus to the trunk.
And their innervation reflects this appendicular function.
It does. They are typically innervated by anterior rami, ventral rami of spinal nerves, often via major nerve plexuses like the brachial plexus or specific named nerves derived from them. The big exception is the trapezius, which gets motor supply from a cranial nerve, the accessory nerve, CNXA.
Okay, so extrinsic muscles move limbs ribs, innervated by anterior rami, mostly. Now, the intrinsic back muscles, these must be the ones that actually control the spine.
Precisely. These are the true back muscles, sometimes called the deep back muscles or epaxial muscles. Their primary job is not moving the arms. Their functions are to maintain posture, fighting gravity, to extend the vertebral column, and to control fine rotational and side-bending movements of the spine itself.
They are the stabilizers and prime movers of the spine.
Exactly. And their defining feature, anatomically and developmentally, is their exclusive innervation. All intrinsic back muscles are supplied by the posterior rami, dorsal rami, of the spinal nerves.
That's the key differentiator.
That's the absolute rule. If you know a muscle is supplied by a posterior ramus, you know instantly it's an intrinsic back muscle, and its primary job relates to spinal function.
Got it. Posterior rami, intrinsic back muscles.
Yeah.
Now, how are these intrinsic muscles organized? You mentioned layers.
Yes, we typically organize them into 3 layers based on their depth: superficial, intermediate, and deep. Starting most superficially among the intrinsics, we have the splenius group.
Splenius, where are they located?
They lie in the neck and upper back, just deep to the extrinsic trapezius and rhomboid muscles. They form a sort of V shape on the back of the neck.
Okay. And this group includes?
It includes 2 main muscles, the splenius capitis meaning head, and the splenius cervicis meaning neck.
Where do they attach?
Splenius capitis runs from the spinous processes of the lower cervical and upper thoracic vertebrae up to the mastoid process and occipital bone of the skull. Splenius cervicis runs from similar lower spinous processes up to the transverse processes of the upper cervical vertebrae.
Okay, so they run upwards and outwards. What's their action?
Their action is pretty straightforward and easy to remember based on their orientation. When both the left and right splenius muscles contract together bilaterally, they act to extend the head and neck. They help you lift your chin or look upwards.
Okay, bilateral extension. What about unilateral contraction?
When only one side contracts, unilaterally, they perform 2 actions simultaneously. They cause lateral flexion, bending the head and neck towards the shoulder on the same side, and rotation of the head and neck, crucially, to the same side as the contracting muscle.
Same side. So they're ipsilateral rotators.
Exactly. Left splenius contracts, you tilt and turn your head slightly to the left. They work together with other muscles like the sternocleidomastoid, but the splenius group pulls posteriorly for extension and ipsilateral rotation lateral flexion.
Got it. Splenius extension bilaterally, ipsilateral rotation flexion unilaterally. Okay, what's the next layer deep?
Immediately deep to the splenius group, we find the immense, powerful muscular mass that really forms the bulk of the intrinsic back muscles, the intermediate layer dominated by the erector spinae group.
Erector spinae. The name implies its function.
It does indeed. This is truly the chief muscular engine of the back. Its primary job is to keep you erect, holding the spine upright against the constant pull of gravity. It's the main extensor of the vertebral column.
And it runs the whole length.
Pretty much. It runs longitudinally along nearly the entire length of the vertebral column, originating from a broad, thick tendon down on the posterior sacrum, iliac crest, and lumbar spinous processes, and extending all the way up towards the skull.
And its main action when both sides contract.
When activated bilaterally, its powerful action is extension of the vertebral column and head, straightening up from a bent-over position or arching the back.
Okay. But it must also control bending forward.
Absolutely critical. When you bend forward slowly, the erector spinae muscles are undergoing eccentric contraction. They are lengthening under tension, acting like brakes to control the descent against gravity and prevent you from just flopping forward. This eccentric control is vital for preventing injury.
Makes sense. Now, you said erector spinae is a group. Is it subdivided?
Yes, this large muscle mass is clearly divided into 3 distinct vertical columns, arranged from lateral to medial. There's a common anatomical mnemonic sometimes used, I love spines, or I love sex, standing for iliocostalis longissimus spinalis.
Okay, let's stick with I love spines. So lateral to medial, iliocostalis longissimus spinalis. Tell us about iliocostalis.
Iliocostalis is the most lateral column. Its name basically tells you its main attachments. It arises from the iliac crest and sacrum, ilio, and inserts superiorly onto the angles of the ribs, costalus, and also cervical transverse processes.
Okay, connects ilium sacrum to ribs neck laterally. What about longissimus?
Longissimus is the intermediate column, and it's typically the largest and thickest of the 3. As its name implies, longest. It has the longest reach. It ascends from the common origin, attaching to transverse processes of thoracic and cervical vertebrae, ribs between the tubercles and angles, and extends all the way up to insert on the mastoid process of the temporal bone of the skull. Longissimus capitis.
Longest and thickest, reaching the skull.
Yep.
Got it. And the most medial column.
The most medial and generally the shortest column is the spinalis. It lies right alongside the spinous processes, connecting the spinous processes of lower vertebrae to those of upper vertebrae. Spinalis thoracis, spinalis cervicis. Some fibers may even blend with semispinalis capatus near the skull.
Spinalis connects spinous processes. Okay, so iliocostalis, longissimus, spinalis, the three columns of the erector spinae, the main extensors, working concentrically to extend and eccentrically to control flexion.
Exactly. When you perform a demanding task like lifting a heavy box off the floor correctly, using your legs, these three columns must contract powerfully and concentrically to straighten and support your back. And as you bend down to place it, they control that descent via that vital eccentric contraction. Hashtag 4. Deep intrinsic and suboccipital muscles.
Okay, we've covered the superficial splenius group and the intermediate powerful erector spinae. Now we need to plunge even deeper, past the erector spinae, into the deepest intrinsic layer, the transversus spinalis group.
That's right. These are often overlooked, sometimes just considered minor assistants to the erector spinae for extension, but they play a much more sophisticated role, particularly in stability and fine control.
Where exactly are they located?
They occupy that groove or gutter between the spinous processes medially and the transverse processes laterally, running deep to the erector spinae.
Okay, in the groove. And what defines this group structurally?
What really defines this group is the characteristic oblique direction of their muscle fibers. Unlike the largely vertical erector spinae, these fibers pass superiorly and medially, running from the transverse processes below up to the spinous processes above.
Like short, angled guy wires connecting transverse to spinous processes.
That's a great analogy, like short, overlapping guy wires. And because they cover shorter segments of the spine, some spanning only 1 or 2 vertebrae, others maybe 4 to 6, they are critically important for 2 key functions beyond simple movement. One is fine-tuning small rotational and extension movements between adjacent vertebrae. But, perhaps even more importantly, the second function is proprioception.
Proprioception.
Yeah.
Sensing the body's position in space.
Exactly. Sensing the position and movement of the vertebral column itself. Think about it. Muscles with shorter fiber bundles generally have a higher density of muscle spindles.
Those are the sensory receptors within the muscle.
Yes, muscle spindles are the sensory receptors that detect changes in muscle length and the rate of that change. So these small, deep transversospinalis muscles, packed with spindles, are constantly sending real-time information back to the central nervous system about the exact position and movement rate of adjacent vertebrae.
So they're like a continuous monitoring system for the spine's posture and movement.
Precisely. They are arguably more important as dynamic stabilizers and proprioceptive monitors than as primary movers.
Fascinating. Okay, how is the transversus spinalis group itself subdivided? You mentioned layers here too.
Yes, we typically divide this group into 3 layers as well, proceeding from superficial to deep within the groove. The most superficial of this deep group is the semispinalis.
Semispinalis.
Its fibers are the longest within the transversus spinalis group, typically spanning or skipping across 4 to 6 vertebral segments as they pass from transverse processes up to spinous processes. It's divided into semispinalis thoracis, cervicis, and a very prominent capitis portion attaching to the occipital bone. It's a powerful muscle, especially in extending the head and neck.
Okay, so it spans 4 to 6 segments. What's its action? Similar to erector spinae.
Bilaterally, yes. Like the erector spinae, bilateral contraction of semispinalis extends the head and vertebral column. But here's the key distinction when it comes to rotation. Acting unilaterally, the semispinalis muscles rotate the vertebral column and head contralaterally, meaning to the opposite side.
Opposite side, unlike the splenius group, which was ipsilateral.
Exactly. If the right semispinalis contracts, it helps turn your upper body and head to the left. Remember, splenius, same side rotation, semispinalis, opposite side rotation.
Got it. Splenius.
Yeah.
Same. Semispinalis opposite. Okay. Deep to semispinalis.
Deep to semispinalis is the multifidus. This forms the intermediate layer of the transversospinalis group. These muscles consist of shorter but notably thick and fleshy bundles that typically span 2 to 4 vertebral segments.
Thicker fibers spanning 2 to 4 segments. Where is multifidus most prominent?
Multifidus is particularly well developed and structurally critical in the highly mobile and heavily load-bearing lumbar region. Here, its fibers provide essential segmental stability, controlling shear forces and fine-tuning movements during dynamic activities like lifting or twisting. Damage or atrophy of the multifidus is strongly linked to chronic low back pain.
So, multifidus is key for lumbar stability.
Got it. And the deepest layer of this group. Finally, the deepest layer consists of the tiny but potentially mighty rotators. These have the shortest fibers of all, spanning just one, rotator breve, or two, rotatores longi, vertebral segments, as they pass almost horizontally from transverse process to the base of the spinous process above.
Shortest fibers spanning one or two segments. Where are they best developed?
They are most distinct and highly developed in the thoracic region. While they technically can produce contralateral rotation, like the rest of the group, their very small size and deep location suggests their primary function might be less about movement and more about pure proprioceptive monitoring.
Like highly sensitive position sensors between adjacent vertebrae.
That's the leading theory. They're thought to act primarily as important proprioceptive monitors, constantly feeding back detailed positional data to the central nervous system, especially during rotational movements where the thoracic spine excels.
Semispinalis, 4-6 segments. Contralateral rotation. Multifidus, 2 to 4 segments. Lumbar stability. Rotatories, 1 to 2 segments. Thoracic proprioception. Makes sense. Are there any other deep muscles below those?
Yes, below the main transversus spinalis group, we find the minor deep layer muscles. These are truly intersegmental, meaning they connect adjacent vertebrae directly.
Okay. Which ones?
These include the tiny interspinales, which run vertically connecting the tips of adjacent spinous processes, and the intertransversarii, which run vertically connecting adjacent transverse processes.
Very small, very deep. What do they do?
They likely function mainly as stabilizers and proprioceptive organs, assisting slightly in extension interspinales and lateral flexion intertransversarii of the vertebral column. They're more like fine-tuners and position sensors than powerful movers. There are also the levatories castarum, running from transverse processes down to ribs, which assist in rib elevation but are grouped with deep back muscles.
Okay, so a whole hierarchy of muscles, from the big movers like erector spina down to these tiny proprioceptive monitors like rotatories and interspinales. Now, stepping back, how does this all work together? The muscle synergy and movement summary.
Well, we've talked about the extensors, erector spinae, semispinalis, working concentrically to straighten up and eccentrically to control bending forward. But it's crucial to remember that almost all movements of the intervertebral joints, except perhaps pure extension in the anatomical position, involve the coordinated action of multiple muscle groups, including those on the front of the body.
Like the abdominal muscles.
Absolutely. Smooth, controlled flexion requires not just eccentric contraction of the back extensors, but also concentric contraction of the anterior abdominal muscles, like rectus abdominis in the obliques, and hip flexors. Similarly, returning to the upright position from full flexion requires powerful concentric contraction of the extensors coordinated with controlled activity of the abdominals to prevent excessive lordosis or jerky movements.
So it's balance. And you mentioned earlier that chronic back strain, perhaps related to excessive lumbar lordosis, often results from an imbalance in this anterior-posterior support.
Exactly. A common scenario is having relatively weak or poor tonicity in the anterior abdominal muscles, lack of core strength. This means the back extensors have to work much harder, both concentrically to produce movement and isometrically just to maintain posture, especially if there's already an increased lordotic curve like from obesity or pregnancy. This constant overwork leads to fatigue, strain, and pain. It highlights the need for balanced strength between the front and back of the trunk.
Okay, balance is key. Let's transition now to that very specialized region at the top again, the suboccipital region and triangle. You mentioned small muscles here.
Yes, this region, located just inferior to the occiput, the back of the skull, is governed by four small, deep muscles. They are the rectus capitis posterior major, rectus capitis posterior minor, obliquus capitis superior, and obliquus capitis inferior.
Rectus, obliquus capitis, sounds like they attach to the head.
They do. They connect the C1, atlas, and C2 axis vertebrae to each other and to the occipital bone. But these muscles aren't about generating large, powerful movements like nodding or turning the head fully.
What are they for then?
They are the fine-tuners. Their main actions involve producing subtle adjustments and precise movements of the head on C1 at leno-occipital joints and C1 on C2 at leno-axial joints. They manage those minute positional changes that allow us to, for example, keep our eyes level and gaze steady while our body or neck is moving. They're critical for head posture and coordinating head and eye movements.
Fine motor control for the head. Got it. And 3 of these form a triangle.
That's right. The rectus capitis posterior major, obliquus capitis superior, and obliquus capitis inferior form the boundaries of the suboccipital triangle. This triangle is a key anatomical landmark.
Why? What's inside it?
The contents are clinically very important. The primary structure passing through the floor of this triangle is the vertebral artery. It runs in a groove on the posterior arch of C1 within this space, just before it turns upward to enter the foramen magnum.
Ah, so the vertebral artery is vulnerable here. Anything else?
Yes, also contained within the space, typically emerging between the vertebral artery and the posterior arch of C1, is the suboccipital nerve.
Which nerve is that?
The suboccipital nerve is the posterior ramus of the C1 spinal nerve. It's primarily motor, supplying these four small suboccipital muscles.
Okay, C1 posterior ramus is the suboccipital nerve inside the triangle, supplying the muscles. What about the C2 nerve?
Now we must be careful not to confuse C1 with C2 here. The posterior ramus of C2 is much larger. It emerges inferior to the obliquus capitis inferior muscle, which forms the bottom border of the triangle, and then typically pierces the semispinalis capitis muscle.
And the C2 posterior ramus becomes?
It becomes the massive sensory nerve known as the greater occipital nerve. This nerve ascends over the posterior aspect of the skull, providing cutaneous sensation to the back of the scalp.
And that's the one often implicated in headaches.
Yes, irritation or entrapment of the greater occipital nerve, C2 posterior ramus, as it passes through the neck muscles is a very common cause of cervicogenic headaches, often described as pain starting at the base of the skull and radiating over the head towards the eye. So, suboccipital nerve, C1, is motor to the small muscles in the triangle. Greater occipital nerve, C2, is sensory to the scalp, running below the triangle.
Great distinction. Okay, finally for the muscle section, let's quickly revisit the clinical box. Back strains, sprains, and spasms. Can you differentiate these common terms?
Sure. It's important to use them correctly. A back sprain specifically refers to an injury involving ligamentous tissue or the attachment of a ligament to bone.
Ligaments sprain.
Right. It happens typically without a full fracture or dislocation, usually resulting from excessive or sudden forced movements like excessive extension or rotation, stretching or tearing ligament fibers. Think of twisting awkwardly.
Okay. What about a strain?
A back strain, on the other hand, involves an injury to a muscle or its tendon. This is the classic injury from overexertion trying to lift something too heavy, especially with improper technique, leading to microscopic tears in the muscle fibers, often in the erector spinae group.
Muscle strain. Got it. And spasm.
A muscle spasm is that sudden, painful, involuntary contraction of one or more muscles. It's often described as a cramp or locking up.
And what causes it?
It's usually a secondary phenomenon, a protective reflex response to some underlying injury, like a sprain, strain, or even a ruptured disc or inflammation nearby. The body tries to immobilize the injured area by clamping down the muscles.
But the spasm itself is painful.
Extremely painful. And the sustained contraction can then cause local ischemia, reduced blood flow, within the muscle, which further irritates nerve endings and can set up a vicious cycle of pain, spasm, ischemia, more pain.
Ouch. Sprain, ligament, strain, muscle, spasm, involuntary contraction, often secondary.
Exactly. And all of this just reemphasizes the importance of proper lifting techniques and ergonomics. When you lift a heavy weight incorrectly, especially holding it far out from your body's center of gravity.
Right, bending at the waist, not the knees.
Yes, you are dramatically increasing the leverage and therefore the compressive and shear forces acting on the intervertebral discs and the passive ligamentous structures. This makes both strains to the overworked muscles and sprains to the stressed ligaments far, far more likely. Using your legs keeps the load closer to the spine's axis.
Okay, having thoroughly explored the bony column, the joints, the ligaments, and the complex muscular layers that protect, stabilize, and move the spine, we now take the deepest dive of all into the vertebral canal itself.
Yes, this canal, formed by the continuous succession of the vertebral foramina stacked one upon another, acts as the ultimate protective bony shield for the most delicate parts of the central nervous system extending outside the skull.
And the primary tenet within this canal is, of course, the spinal cord.
The spinal cord itself. Understanding its basic structure and extent is absolutely foundational for pretty much all of neuroanatomy and clinical neurology.
Where does it begin and end?
It's continuous superiorly with the medulla oblongata of the brainstem, passing through the foramen magnum of the skull. It then extends downwards within the vertebral canal until it tapers to an end. This tapered conical inferior end is called the conus medullaris.
The conus medullaris. And where does that typically end in an adult? This seems clinically important.
It is critically important. In the vast majority of adults, the conus medullaris terminates at the vertebral level of L2, or sometimes the L1-L2 intervertebral disc. It does not extend the full length of the vertebral canal.
Only down to L2. Why is that termination point so essential to know?
Because it creates a significant region within the lower lumbar vertebral canal that contains cerebrospinal fluid and nerve roots, but not the delicate spinal cord tissue itself. This creates a relatively safe zone below L2 where procedures like lumbar punctures can be performed with minimal risk of directly injuring the spinal cord.
Ah, the safe zone for lumbar taps.
Okay.
Got it. Now, is the spinal cord uniform in diameter all the way down to the canunus?
No, it isn't. It exhibits two noticeable swellings or enlargements along its length. These correspond to the regions where the nerves supplying the upper and lower limbs arise.
Makes sense. More neurons needed for the limbs.
Exactly. There's a cervical enlargement roughly from the C4 to T1 spinal cord segments, which contains the extra neurons needed for the complex innervation of the upper limbs via the brachial plexus.
Okay, C4T1 for arms, and the lower one.
And then there's a lumbosacral enlargement, typically from about the L1 to S2 or S3 spinal cord segments. This enlargement houses the neurons for the lower limbs, innervated via the lumbar and sacral plexuses.
L1, S2, S3 for legs.
Yes, sir.
Got it. Now, emerging from the cord along its length are the spinal nerves and roots. How are these formed?
We have 31 pairs of spinal nerves in total, named and numbered according to the vertebral level from which they emerge. Each spinal nerve is formed by the union of two distinct roots that attach to the spinal cord.
Two roots, anterior and posterior.
Yes. There's a posterior or dorsal root, which contains primarily sensory nerve fibers. You can usually identify the posterior root because it has a swelling on it called the posterior root ganglion, or dorsal root ganglion, which contains the cell bodies of these sensory neurons.
Okay, posterior is sensory, has ganglion.
And then there's an anterior or ventral root, which contains primarily motor, efferent nerve fibers carrying signals out from the spinal cord to muscles and glands.
Anterior is motor, and these two roots join.
These two roots, posterior sensory and anterior motor, converge and unite just proximal to, or sometimes right within, the intervertebral foramen to form the mixed spinal nerve. Mixed because it now carries both sensory and motor fibers.
Okay, and the numbering system, 31 pairs.
The segmental organization is critical. There are 8 pairs of cervical spinal nerves, C1, C8, 12 pairs of thoracic, T1, T12, 5 pairs of lumbar, L1, L5, 5 pairs of sacral, S1, S5, and 1 pair of coccygeal nerves, C1.
Wait, 8 cervical nerves but only 7 cervical vertebrae? How does that work?
That's a common point of confusion. The rule is cervical spinal nerves C1 through C7 exit the vertebral canal above their correspondingly numbered vertebra. For example, C5 nerve exits between C4 and C5 vertebrae. However, the C8 spinal nerve exits below the C7 vertebra between C7 and T1.
C8 is the transition point.
Exactly. From T1 downwards, all spinal nerves exit below their correspondingly numbered vertebra. For example, L4 nerve exits between L4 and L5 vertebrae. That existence of the C8 nerve shifts the numbering relationship below the neck.
Got it. Now, you mentioned the spinal cord ends at L2, but the vertebral canal goes way down to the sacrum. What happens to the nerve roots for the lumbar and sacral levels?
Since the spinal cord is much shorter than the vertebral column, the nerve roots arising from the lower segments of the cord, particularly the lumbosacral enlargement, have to descend a considerable distance within the vertebral canal before they reach their appropriate intervertebral foramen to exit.
They have to travel downwards from the conus medullaris.
Precisely. These descending lumbar, sacral, and coccygeal nerve roots, below the termination of the spinal cord proper, below the conus medullaris, form a striking bundle of nerves floating in the cerebrospinal fluid.
And this bundle is called?
This bundle is famously called the cauda equina, which is Latin for horse's tail, because that's somewhat what it resembles.
The cauda equina, so that's what fills the canal below L2.
Yes, the lumbar cistern, which we'll discuss more below L2, contains the CSF and this collection of descending nerve roots forming the cauda equina on their way to exit the appropriate lumbar, sacral, or coccygeal foramina.
Okay. One more structural point.
Mm-hmm.
How is the spinal cord anchored inferiorly? Does it just float or is it tethered?
It's securely anchored inferiorly by a structure called the filum terminale.
Filum terminale. Is that nerve tissue?
No, importantly, it is not nerve tissue. It's a delicate, non-nervous, fibrous strand that is actually an extension of the innermost meningeal layer, the pia mater. It arises directly from the very tip of the conus medullaris.
So a pile extension from the cord tip.
Yes. And it extends downwards through the lumbar cistern, surrounded by the cauda equina. It eventually pierces the dura mater around the S2 level and continues downwards outside the dural sac to finally blend with the periosteum on the posterior aspect of the cosmprices, the tailbone.
So it tethers the cord all the way down to the cosmprices.
Essentially, yes. The part inside the dural sac is called the filum terminale internum, and the part below S2 that attaches to the cosmprices is the filum terminale externum, or conchoidal ligament. This anchoring ensures the spinal cord remains relatively stable within the vertebral canal during movements like bending forward or backward, preventing excessive tension or upward migration of the cord. Hashtag Tag 6, spinal meninges, CSF, and vasculature.
Okay, we know the vertebral canal provides the bony protection, and inside we have the spinal cord, nerve roots, and the cauda equina. But the cord itself has its own immediate protective layers, right? The spinal meninges.
Exactly. Just like the brain, the spinal cord is enveloped by 3 protective connective tissue membranes, the meninges. They provide support, protection, and contain the cerebrospinal fluid.
3 layers, from outermost to innermost.
From outermost to innermost, they are the dura mater, the arachnoid mater, and the pia mater. You can remember the order with the mnemonic PAD, pia arachnoid dura, from deep to superficial, or DAP, from superficial to deep.
Okay, let's go superficial to deep. Dura mater first.
The dura mater is the outermost layer. It's a tough, dense, fibrous, non-elastic sheath. It forms the spinal dural sac, which is a long tube extending down within the vertebral canal.
And how far down does the dura go? Does it end with the cord at L2?
No, this is another crucial anatomical point. The spinal dural sac extends much lower than the spinal cord itself. It typically terminates inferiorly at the level of the S2 vertebra.
S2. So well below the cord's end.
Yes. This means the space between L2, cord end, and S2, dural sac end, is filled with CSF and the cauda equina, but no spinal cord. That's the lumbar cistern we keep mentioning.
Okay. Does the dura do anything else?
Yes, as the spinal nerve roots exit laterally, the dura mater extends outwards along them for a short distance, forming dural root sheaths, or sleeves, that blend with the epineurium of the spinal nerves near the intervertebral foramina.
Okay, dura is the tough outer sac down to S2. What's the next layer, deep to the dura?
The middle layer is the arachnoid mater. This is a much more delicate, avascular, lacks blood vessels membrane that lines the inner surface of the dura mater. It doesn't adhere tightly to the dura, but it's held against it by the pressure of the cerebrospinal fluid.
Arachnoid. Sounds like spider.
Exactly. It's named for the fine web-like strands, called arachnoid trabeculae, that extend from its inner surface across the space below it to connect to the deepest layer, the pia mater.
Okay, delicate layer with web-like strands. And the innermost layer.
Adhering directly and intimately to the actual surface of the spinal cord, following all its grooves and contours, is the innermost layer, the pia mater. Pia means tender or delicate.
Pia clings tightly to the cord.
Very tightly. It's a thin, transparent layer rich in blood vessels that supply the cord. And the pia mater isn't just a simple wrapping, it also forms 2 important anchoring structures.
Which are?
We already mentioned one, the filum terminale, the inferior anchor, which is a pile extension from the cornus medullaris.
Right.
The other structures are the denticulate ligaments. These are paired, tooth-like denticulate triangular extensions of pia mater that project laterally from the spinal cord, midway between the posterior and anterior nerve roots.
Tooth-like ligaments. What do they attach to?
Their points, or teeth, pierce the arachnoid mater and attach firmly to the inner surface of the dura mater along the length of the cord. There are about 21 pairs of these.
And their function?
They act like lateral guy ropes, suspending the spinal cord within the dural sac and anchoring it laterally. This helps to stabilize the cord against side-to-side motion or rotational stress within the vertebral canal.
Okay, so dura, outer sac to S2, arachnoid, middle web, pia, inner layer forming filum terminale and denticulate ligaments. Now, these layers define some important meningeal spaces. Let's clarify those. What's the space outside the dura?
The space outside the dura mater, lying between the dura and the periosteum lining the bony vertebral canal, is the epidural space. Note, in the spine, this is a real space, unlike the cranial epidural space, which is potential.
The epidural space. What's normally found in there?
The spinal epidural space is quite distinct. It's not empty. It's filled primarily with fat, loose connective and adipose tissue, which acts as padding.
Okay, fat.
And also, crucially, it houses that extensive network of internal vertebral venous plexuses, those valvulus veins we discussed earlier.
Ah, the veins are in the epidural space.
Yes. And importantly, inferior to the L2 level, this space also contains the spinal nerve roots after they have exited the dural sac, but before they pass through the intervertebral foramina, still ensheathed in their dural sleeves.
So fat, veins, and exiting nerve roots below L2. This is the target for epidural anesthesia.
Exactly. Injecting anesthetic into this space bathes the nerve roots as they pass through, blocking nerve transmission.
Okay, that's the epidural space. What about the space between the dura and the arachnoid?
That's the subdural space. However, in normal conditions, this is considered a potential space. The arachnoid is usually pressed up against the dura by CSF pressure, so there's no actual gap unless some pathology like bleeding, a subdural hematoma, forces the layers apart.
Potential space. Got it. So the main fluid-filled space is...
The main naturally occurring fluid-filled space is the subarachnoid space. This is the space located between the delicate arachnoid mater externally and the pia mater internally, which is stuck to the cord.
between arachnoid and pia, and this contains...
This space contains the vital cerebrospinal fluid, CSF, which circulates around the spinal cord and brain, providing buoyancy, shock absorption, nutrient delivery, and waste removal for the central nervous system.
CSF is in the subarachnoid space.
Yes, and within this space, you also find the arachnoid trabeculae spanning it, the spinal nerve roots traveling through it before they pierce the dura, and the major blood vessels, arteries and veins, supplying the spinal cord itself.
Okay. And that enlargement of the subarachnoid space below the end of the spinal cord is the lumbar cistern.
Precisely, because the spinal cord ends at L2, but the dural and arachnoid layers continue down to S2, this creates a large cistern or reservoir of CSF in the lower lumbar region.
From L2 down to S2.
Correct. This lumbar cistern contains the CSF, the filum terminale internum, and the floating nerve roots of the cauda equina, but crucially, not the spinal cord proper.
And this anatomical arrangement is what makes lumbar puncture safe.
Exactly. It provides that safe window for inserting a needle into the subarachnoid space to sample CSF for diagnostic purposes or inject drugs therapeutically without the risk of hitting the spinal cord. You're just pushing aside the nerve roots of the cauda equina within the fluid.
Brilliant design, really. Okay, let's discuss the life supply running within or near these layers. The arterial supply of the spinal cord. How does the cord itself get blood?
The spinal cord receives its blood supply primarily from two sources: longitudinal arteries that run along its length, and segmental arteries that reinforce the supply at various levels.
Longitudinal arteries first. How many and where?
There are typically three main longitudinal arteries running the length of the cord. There is one anterior spinal artery, which is usually formed by the union of branches from the two vertebral arteries up near the brainstem. This single artery runs downwards within the anterior median fissure of the spinal cord.
One anterior, what about posterior?
And there are usually two posterior spinal arteries. These typically arise from either the vertebral arteries or the posterior inferior cerebellar arteries, PICA, and run downwards along the posterolateral aspects of the spinal cord near where the posterior nerve roots enter.
Okay, one anterior, two posterior. Do these three arteries supply the whole cord sufficiently on their own?
Often, no. Especially in the lower cervical, thoracic, and lumbar regions, the blood flow solely from these three longitudinal arteries can be insufficient. They rely heavily on reinforcement from segmental medullary arteries.
Segmental medullary arteries. How are these different from the spinal branches we talked about supplying the vertebrae?
The spinal branches enter the intervertebral foramina. Some of these branches primarily supply the vertebrae and meninges. Others, however, continue on to become segmental medullary arteries. These larger reinforcing vessels run along the nerve roots, pierce the dura, and anastomose connect with the anterior and/or posterior spinal arteries, boosting their blood supply.
So they are feeder arteries coming in from the sides.
Exactly. They are crucial feeders entering at various levels. However, there aren't that many of them. Maybe only 6 to 10 significant segmental medullary arteries along the entire cord length.
Only 6 to 10. That sounds vulnerable.
It is, and the distribution is often uneven. There's frequently one particularly large and critical segmental medullary artery, known as the great anterior segmental medullary artery, or the artery of Adamkiewicz.
The artery of Adamkiewicz. Where does that usually come in?
It most commonly arises on the left side, somewhere between the T9 and L2 vertebral levels, although this can vary. Its importance lies in the fact that it often provides the major blood supply to the lower two-thirds of the spinal cord, including the lumbosacral enlargement.
Wow, so compromising that one artery could be devastating.
Absolutely devastating. If the artery of Adamkiewicz is occluded or damaged, for example, during aortic surgery, trauma, or dissection, it can lead to immediate and severe ischemia of the spinal cord in the lower thoracic and lumbar regions, resulting in paralysis and sensory loss below that level, anterior spinal artery syndrome.
That highlights the critical dependence on these few reinforcing arteries.
Mm.
Now, you also need to distinguish these medullary arteries from radicular arteries.
Yes. While segmental medullary arteries run along nerve roots to reach and supply the spinal cord itself, there are also smaller radicular arteries. These also rise from spinal branches and run along the nerve roots, but they primarily supply only the nerve roots, anterior and posterior, and their dural coverings. They don't typically provide significant reinforcement to the main spinal arteries supplying the cord parenchyma.
So medullary arteries feed the cord, radicular arteries feed the roots.
Correct. Clinically, compromising a radicular artery might lead to nerve root symptoms, radiculopathy, whereas compromising a medullary artery can lead to catastrophic spinal cord infarction, myelopathy.
Got it. And the venous drainage. Does it mirror the arterial supply?
It does, broadly speaking, but it's perhaps more diffuse and redundant. There are typically 3 anterior and 3 posterior spinal veins running longitudinally along the cord, receiving blood from within the cord substance.
Okay, longitudinal veins, where do they drain?
These spinal veins communicate freely and drain primarily into that extensive network we keep mentioning. The internal vertebral venous plexus is located in the epidural space.
Back to the valvulus plexus.
Back to the valvulus plexus. From there, blood eventually drains out via intervertebral veins, which pass through the intervertebral foramina alongside the spinal nerves, ultimately connecting to the major segmental veins of the body, like zygos, lumbar, vertebral veins.
So cord drains to spinal veins, which drain to the internal plexus, which drains out via intervertebral veins.
Okay.
Given this detailed map of layers, fluids, spaces, and vasculature, let's revisit the 2 key clinical procedures relating to this space, just to solidify them. First, the lumbar spinal puncture, or lumbar tap.
Right. As we've established, this procedure is done specifically to sample CSF, usually for diagnostic purposes, like checking for infection, inflammation, or bleeding.
And the key landmarking.
It's performed below the level of the coneus medullaris, which ends at L2, to avoid injuring the spinal cord. The needle is typically inserted in the midline between the spinous processes of either L3 and L4 or L4 and L5 vertebrae.
How do you find those levels easily?
Clinicians use the iliac crests as a landmark. A line drawn horizontally between the highest points of the iliac crests, the intercristal line or Tuffier's line, usually passes through the spinous process of L4 or the L4-L5 inner space. This provides a reliable way to identify a safe level for insertion.
Okay, find L4, L5, or L3, L4 space. What layers does the needle pass through?
The needle passes sequentially through the skin, subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum, then the epidural space containing fat and veins, the dura mater, the arachnoid mater, and finally enters the subarachnoid space, the lumbar cistern.
And you feel pops as you go through ligaments and direct.
Yeah. Often, yes. Experienced clinicians can feel distinct changes in resistance, particularly a pop, as the needle penetrates the ligamentum flavum and then the durarachnoid complex to enter the low-resistance subarachnoid space, allowing CSF to flow out.
Okay, that's the lumbar tap into the subarachnoid space. Now contrast that with epidural anesthesia or epidural blocks.
For an epidural, the goal is different. Here, the anesthetic agent is injected specifically into the epidural space, that space outside the dura mater, the one containing fat, and the internal venous plexus.
So you don't puncture the dura and arachnoid.
Correct. The needle passes through the same initial layers, skin, ligaments, but stops once it enters the epidural space, typically identified by a loss of resistance technique using air or saline. The anesthetic is then deposited there.
And how does it work if it's outside the dura?
The anesthetic solution spreads within the epidural space, bathing the spinal nerve roots as they traverse this space after exiting the dural sac, but before leaving the vertebral canal via the intervertebral foramina. The anesthetic blocks conduction in these nerve roots, providing regional pain relief, analgesia, or complete blockade, anesthesia, depending on the concentration used.
Affecting the nerve roots in the epidural fat and veins?
Exactly. It acts directly on the spinal nerve roots passing through that space. Because it doesn't directly enter the CSF or affect the spinal cord itself, unless there's accidental dural puncture, it tends to have fewer central nervous system side effects than spinal anesthesia, where anesthetic is injected directly into the CSF via lumbar puncture.
Great. So the key distinction is the target space, subarachnoid space containing CSF for a lumbar tap spinal anesthesia versus epidural space containing fat veins roots for an epidural block.
That's the fundamental difference in technique and effect. #tagout Triduum.
Wow. Okay, we have really covered a lot of ground today. We've navigated the precarious stability of the craniovertebral complex up top. We've mapped the intricate intrinsic muscular architecture, layer by layer, contrasting, the raw power of the erector spinae
Yeah.
with the delicate proprioception of those deep rotitors.
Mm-hmm.
We traced the winding segmental path of the blood supply with its critical choke points like the artery of Adamkiewicz,
Yeah.
and we explored the protected realm of the spinal cord and its meninges, right down to that vital lumbar cistern.
It's truly fascinating when you step back and realize that the back stability isn't based on just rigid stacking like building blocks. It's founded on this continuous dynamic muscular monitoring and adjustment,
Right.
supported by a system of bones and ligaments that has to constantly negotiate this compromise between allowing mobility and providing protection. And like you said, understanding that the deep transversospinalis group is essentially a sensory feedback system really changes how we should think about rehabilitation for things like chronic back instability. It's not just about brute strength.
It absolutely underscores the complexity behind seemingly simple actions like bending over or turning your head. And let's just circle back for a final thought on that unique anatomical risk we discussed. Given the high density of fat and that extensive network of valveless internal vertebral veins packed within the epidural space,
Yeah.
how might the sheer mechanical force exerted when you simply cough hard or sneeze violently or strain significantly, how might that simple pressure change influence the rapid unfiltered spread of, say, infection or metastatic cells from an initial site, maybe low down in the trunk, directly up that venous plexus highway toward the base of the skull or even into the brain?
Sobering thought.
That anatomical path via that valveless system,
Yeah.
it seems alarmingly wide open, bypassing many of the body's usual filters. Something to really consider clinically.
Definitely something to keep in mind. That venous plexus is a unique and often underestimated pathway.
Okay, well, that closes out our deep dive into Chapter 2 on the back. Next time, we shift gears completely.
We do. Next deep dive, we begin our detailed study of the upper limb, starting right at the beginning with its foundational bones and the fascial compartments that organize its structure.
Looking forward to it. We'll see you then. Bye.